To everyone who is present here now for the last day session. You know that we have been discussing the most important topics. There are 20 topics that has been mentioned in the CBME, including the EdCom. We are focusing on the most important topics at first day. That's why we covered communication and then on pain and then on end of life care today. So there are no subdivisions today. You have to discuss the topic. So you might have seen, if you have gone through the folder, there are certain headings under which we have covered end of life care. There are headings on palliative sedation, ethical decision making, how to manage symptoms, goals, how to set goals of care. So everything has been, so there are several components under which end of life care should be covered for medical students. So like last day, we'll quickly go to the groups and come up with a plan. And today, by the time you come to the larger groups, we'll discuss, and it's the same heading that you will be discussing, but that I hope there will be different teaching methodologies from each. So kindly give some respite to the people who have been doing all the work in the last 2 days. Please volunteer yourself in the group and don't waste time deciding who is going to present. Just someone present. Anyway, we all know each other for such a long time. So it is just about sharing your learning. So assigning you to the groups, and we'll see you after 30 minutes and start with the discussion.
In the time of at the time of training.
What plan?
Poppy plant, morphine plant, sir. In Barabanki, there is a production of the poppy plant.
Sri, I have MP and UP and all. I have traveled so much. I have also gone to the headquarters of the Narcotics Commission of India. And actually lived there for a day. Still, I have not seen a poppy plant in person.
Yes, sir. Yes, sir. I will definitely give to you, sir. I'm trying to collect.
I
Then
think
he will be caught by the Kerala police very soon.
I mean, both of us, both of us. both of
Yes.
us. She as the courier and I as the brain behind it. Both of us will get arrested. So Smita, don't do anything. Anything adventurous. It's okay to, I can live with the fact that I have not seen a poppy plant. It's okay.
So thank you, everyone. Welcome back to the larger group. One group was totally silent and dead. So we had to remove Dr. Kalindi from that group to another group. So we made a little rearrangement in many groups. Sorry for that. Anyway, those who have discussed, we are so glad that you have you are actively discussing these topics in the group, and those who are silent might have understood the challenges of having a group discussion with students. If you yourself can't participate, I'm not sure how can we actually engage students in a group discussion. So these are the real ground realities when you conduct group discussions. Thank you so much. Group 1, without wasting time. Do we have a speaker from group 1? Dr. Harishankar, Dr. Devashish, who's the speaker from your?
I am Dr. Sreedevi.
Okay, ma'am. Okay, please go ahead. Ma'am, I think you can switch off your video. You have network issues, I think. Your network.
Hello. Yes, ma'am. I am traveling. The topic is goals of your discussion at the end of life.
Ma'am, I think you have network issues.
This session is. Ma'am, can you give me 10 minutes? Then I will after
So you put some other group on.
Yes.
Will Dr. Shatanuruba will come back later.
Sure, sure.
After 10 minutes. Okay.
Thank you, Dr. Shatanuruba. We'll come back to you in another few minutes. Group 2. I think group 2 was the group which we had to dissolve because of no response. Group 3.
Yes. Good
Yes, Dr.
afternoon,
Manisha.
everyone.
Yeah.
Yes,
Please
I'm
go ahead.
Dr. Manisha from Group 3. Yes, ma'am. Just I wanted to tell you about the teaching methods which our group has suggested for end of life care. First of all, we'll set induction by showing them a video with a case scenario of a patient who has end of life care symptoms, like a case of lung cancer patient with severe vena cava obstruction can be shown, who has severe headache, vomiting, and respiratory depression, which shows that there is brain metastasis, and patient is in his end of life stage. So we can brainstorm the students about what they will do at this stage, whether what they want, what should be the decision, whether to keep the patient in the hospital setup or ICU setup, or or she should be referred back to the home, or how to counsel their family members, how to know about their decisions, since they have their classes on communication. So this can be assessed by brainstorm. Then we can proceed towards the didactic lecture or PPT showing them about the prognostication and how the symptom management can be done in the end of life care patient. And we can also use the teaching method like we are doing here in the classroom. After showing them the videos, we can ask them to split them into different groups and give them the case scenarios showing one or the other symptoms, and then they can come back after their group discussion and present in the larger group as we are doing it here. And evaluation can be again done by the pre-test and post-test, by MCQs or short answer questions can be asked. Then we can give them the scenarios, and we can again ask them to prepare and reflect back or they can write the reflections that what they have learned in the whole class. So this is how we can do the teaching and assessment of the students with end of life.
Thank you, Dr. Manisha. Maybe I missed in the beginning. So how will you convey the students that why do we need to plan goals of care when someone is dying? Like this, otherwise this will be
Ma'am,
like
we
any
can show
treatment
them.
plan, right? Yes, ma'am, please.
Ma'am, first of all, I hope that we can set induction by showing them a video where we can show them a patient who is fighting with such symptoms which are at the end stage of life. And then we can brainstorm them that what they think they will do at this stage. Because we have already, as we were not told about that we have a second year or third year students, but ADCOM has already shown them the communication skills. So how will they counsel the patient or their family members that what respecting his or her autonomy, whether he wants to be in the last stages, he want to be in the hospital setup, or the family members, their decisions, how will they know their decisions? This was just brainstorming them about their prior knowledge and then proceeding towards the teaching. That was what I told you initially.
Thank you, Dr. Manisha. Sorry for asking more. So till then, they might have learned to focus on the diagnosis and the curing part. Suddenly, we are telling them to focus on the goals of care, right? It's very different from what they might have actually seen in their early clinical exposure or in their clinical posting. So I'm just putting
Yes.
that thought. I am not looking for answers right now, but taking them from where they are used to hear about the diagnosis and come up with a treatment plan where you write medications. Here you are talking about, you're not focusing literally on the diagnosis part, but we are talking about someone who might be dying, and we need to focus on how to care for this patient. So that shift should be very clear for the students, and they should understand. Otherwise, they'll end up in coming up with a medication plan with in the group discussion. They'll come up with all those, send them for tests, understand why this hyponatremia is happening. That will be the output of that discussion, right? So maybe in the beginning, as you said, a video where you can ask. You are mentioning that you will ask them like how, what do you
Yes,
want to focus
diagnosis
here?
of dying is very important, first of all.
Yes.
The diagnosis of dying is very
Yes,
important, first
yes.
of all, and why should be treating him diagnose the impending death? That is very important to teach the students.
I think I heard Dr. Niladri talking about a case scenario, right, where a cancer patient and then going on to end of
Yes,
life
yes.
care. So
That
yeah, so that maybe you can move
yes, that
sequentially.
scenario.
Yes, ma'am. Sorry to interrupt.
Yes, ma'am, that's what I told. Then we'll give them the case scenarios and ask them to come in groups about
Yes.
how they will handle.
Thank you so much.
The same case scenario.
Sorry, I missed.
Yes, ma'am, I was telling the same case scenario which I told. That was what
Yes.
we discussed in the group.
Yes, got it. So maybe sequentially you can start, and then gradually the patient is going in. That's a very good plan. Dr. Devashish, you have something to add?
Yes, ma'am. At the onset, we should emphasize or say what is good death. The concept of good death, it is the death that is free from avoidable distress and suffering for the patients, families, as well as the caregivers. So this should be emphasized at the onset. Then the types, decisions making, end of life care, the core part will come.
Thank you, Dr. Devashish, for pointing it out. Dr. Rajagopal?
Thank you, everybody. I suppose this means that all of you, whether I know that a majority of the group belong to radiotherapy, so you do not have ordinarily responsibilities with undergraduate teaching. Nevertheless, we will realize that most faculty members in the country, except for some unusual people like Sumita and Sarida, who are already palliative care physicians, in the majority of colleges, there'll be nobody to teach the subject effectively. So I hope you will be able to jump in and help them as adjunct faculty members for this purpose. Dr. Neeladri mentioned the importance of prognostication of death, and I totally agree. We are not used to doing that. Our ancestors had this automatically, that knowledge. They were familiar with death. Our my grandfather's generation could tell when somebody was dying from experience. We have lost that experience, and even doctors. Just a couple of weeks, about 3 weeks back, I was talking to a group of house surgeons who said when they went on home visits with a palliative care team, was the first time they saw somebody dying. So things are as bad as that. So prognostication is something we should get familiar with. Having said that, Dr. Neeladri and others, I must point out that it can be, our prognostication can go wrong. And even in the rather once famous Liverpool care pathway, it is acknowledged that the people who are put on the pathway for dying, end of life, sometimes come back. So that's a possibility we'll bear in mind. And especially arising from that, it is particularly important to start end-of-life conversations early. Early on, there are many ways in which it could be brought in. If that could also be conveyed, that will be nice. And Dr. Kalandi, I also thank you for your recommendation. She says we can ask students to share if any have personal experience of anybody known to them dying in an ICU or at home. Absolutely. The only, I do this fairly routinely when we have enough time. The one couple of things that we will be careful about is in advance warn them. If you think you are going to be very emotional about the experience, maybe this classroom is not the right place. If enough time has elapsed and you feel comfortable talking about it, please do that. And please be brief. Think about the highlights of the event and tell us in 5 minutes. Because otherwise, two things happen. If it's a recent occurrence, sometimes they break down. And then we can't just change the subject and walk away. Some time is spent on that, which we cannot afford to do in this context. Secondly, unless we warn them about the time limit, you may have 1 hour and 30 minutes may be taken up by the sharing of experience. But it's a very powerful tool. Thank you.
Group 1 is ready, Dr. Shadrupa.
Yes, ma'am. Ma'am, our student must be, I think our topic is goals of care discussion at the end of life. The student must be 4th year MBBS student. There will be 2 sessions, each will be 1 hour duration. And after the session, student must be able to explain the principles of end of life care discussion and the methods and importance of prognostication. Firstly, we must discuss where goals of care discussions are relevant. In not all cases that are relevant, but mostly which cases we must, these are important. We must discuss about in the students. We must do some framework for goals of care discussion and how it helps in decision making and access to end of life care. Then there must be a lecture with PPT presentation along with video. In PPT, we must highlight the end of life care involves, that is the care delivered with excellent clinical skills, compassion and understanding with maintaining the patient's dignity and wishes also. In the PPT, there must be, we must give importance about the physical, psychosocial, spiritual and practical aspects of patient needs. We must recognize and accepting the terminality of the disease. We should decide against inappropriate treatment. We must control the symptom and to care of the comfort of the patient. We must communicate sensitively to the family and we must help them to part of the decision making process. We should discuss them about the advantage and disadvantages of the home-based care, hospice care, and hospital care among the patient. With some patient parties may be benefited with home care, some may be with hospice, and some may be hospital care. Then we plan accordingly. We may transition patient from ICU to palliative care. We may include palliative team. We may give support, psychosocial and spiritual. We give bereavement support also. We must discuss among the students some case, some scenario we may discuss, and we will give some MCQ questions to the patient, and we must assess accordingly. We will divide the patient in small groups, and in each group we should give a different case scenario, some malignant and some may be non-malignant also. And after the discussion, we will be able to know how much student will be able to cope up with the topic. And at the end of the discussion, this is the first session, and the second session will be about the prognostication. This is a new topic for the patient, a new topic for the student. There must be some objective learning objectives for prognostication. That is why it is important in decision making and access to palliative care, and what are the available methods of prognostication. Again, there will be some lecture with PPT and some case discussion. After the lecture and PPT, we will evaluate the groups of students according to some MCQ test and along with some post test also. At last after the test result, we give a summary to the student that we must focus on the comfort on patient. We must review the symptom regularly. We must balance what is need and what is want. Using the ethical rule, we must give necessary management. We must manage the necessary distressing symptoms. Least invasive route of drug we should choose. Effective communication with the patient and family members. We must address the grief and bereavement support also. This all from my part. Thank you.
Thank you so much, Dr. Shatrupa and Group 1. Just one question. What challenges do you think you will face while teaching this topic to final year students?
I think the end of life care is really a new topic for they think about the cure of the disease. So end of life care must be a new topic for four-year MBBS students. I think this must be a very new topic for them. What are the challenges we face daily and what should we do? It must be in the MBBS curriculum also.
Over to you, sir. Sir, you muted.
As usual. Thanks, Sri. Shatrupa?
Yes, sir.
I was looking up the meaning of your name in Google. You know, friends, do you know what it means? It means she of 100 beautiful forms. The first human female to be created by Lord Brahma, supposed to be Lord Brahma's daughter. Thank you, Shatrupa. How do you pronounce your name?
Shatrupa. I am a Bengali, sir, so I
Okay.
pronounce it in Shatrupa.
Okay. Thank you for your comments. Sri, I think I agree with everything that was said. It's not as if I have many word of dissent. Yes, the subject is new to students, and but everybody must have gone through the experience of no, not everybody. Every doctor would have gone through the experience during house surgency, facing a dying patient, and then not knowing what to do. I went through that. So the Dr. Bernal's comment as well as Dr. Kalandi's comments, previous comment, are all very valid here also. When somebody talks about a personal experience, then it's easy to bring the subject in. They will understand the relevance immediately. Thank you.
There is another video which I'll be sharing soon where a son and the daughter-in-law talking about how it was for them when their mother was approaching end of life care, like what they went through and what were the difficulties they had and what were the good things that they experienced. Maybe that kind of videos can be a trigger, or in between the lecture, maybe we can use how the caregivers feel once their loved ones pass away and how they die. And if you have a palliative care department, if any caregiver is ready to talk for 5 minutes, I mean, there are ethical issues there, but still, if you can get someone who is ready to share, some people really want to share their experience. So if you can find someone like that, that's one way of teaching and understanding that what do the caregivers feel when all this is happening in their life.
Sri, will you be sharing the video with all the participants? Videos, etc.?
Yes, sir. Yes, many of them we have already shared, and rest of it we'll be sharing the Google Drive link because there are a lot of videos.
Okay.
So they can choose. We have named all the videos. So just look at the names and use whichever ones you want to use.
Okay,
All the
very good. Very good.
Many of them are already shared. So next group 3. I think you have already done. I think it's group 4. Group 4, I think I've seen only Dr. Shivani and Dr. Priyanka. Yes, Dr. Priyanka, please.
Good afternoon, everybody. Today we discussed about the goals of care in case of end of life and how to prognose. Like the topic for the students will be the goal of care for the end of life during the end of life for the terminally ill patient, how to prognosticate the patient, and regarding the palliative sedation in end of life. So here first the student should be able to first of all define who is the terminally ill patient. He should be able to identify the terminally ill patient, like cancer patients who have advanced cancer or who are chronically ill patients who will not respond to the curative treatment. In those cases, instead of giving futile treatment, they have to they have to be shifted to palliative care to decrease the suffering. So objectives will be whether to prognosticate the patients, make a shared decision, and discuss about the ethics related to the treatment of caring during the end of life. So the student at the end should what we can do is we can give a didactic lecture regarding all these topics. Like students should be able to prognosticate the patient when the curative, because most of the students, what happens is that they are oriented towards curative treatments during their MBBS. In their MBBS curriculum, most of the treatment goes towards the discusses about the curative treatment. So they are not used to discuss. They are not used to define the. They are not able to prognosticate the patient. Their intention is always to give a curative kind of treatment. So they cannot. So at the we will discuss regarding the prognostication when the patient will not need curative treatment and when the palliative treatment should be started for the patient. And then when during our main aim for the treatment should children should define should know what should be the aim of the treatment, that they should know that the dying of a patient should be symptom free, patient should die peacefully, and the suffering should not be there in the patient should not be dying with suffering. And in addition to that, the family members should also be because in these cases the family members, they are also suffering along with the patient. So we should be able the patient's family members, they should also be able to we should also care about them. they should also know how to deal with this kind of situation. And in addition, our goal of treatment will be should be ethical, like it should be unnecessary. We should not give any kind of unnecessary treatment. When a cure is not possible, that time we should not be giving the, and the autonomy of the patient should also be respected. That is if the patient there are cases when patient feels that I need treatment, and family members, they are we have discussed with the family members that they should keep the that there's no need of treatment, but the patient feels that my family members, they're not taking care of me, they're not giving me treatment. In that cases, shared decision has to be taken, that we should discuss with the patient also, that in such cases we can give a hospice kind of treatment, where patient feels that he's being taken care of. And then we can give, along with the didactic lectures, videos can be shown to the students regarding how we have to take care of this kind of situations. And we should actually, at the
no problem, it's okay. Yeah, you can.
at the end, actually, we can give MCQs based on the what teachings, what we have taught to the students, and evaluate the MCQs, and give case scenarios and discuss regarding the case scenarios also.
I also want to add something. I am so in this group.
Yes, ma'am, please.
At this moment, because the MBBS students are enthusiastic and they read and they know curative treatment. So we should also try that these students should treat up to some extent, not very much, but there are something they should know that there are something which cannot be treated. This type of mindset should be, these students should be there, I think. Number one. Number two, they should also know the detail about the ethics of the patient. Ethics about that. That is what is autonomy. They should know, because we are seeing that the students are coming up, the MS, they do this type of things. They do all the things in the operation theater. They do things which is important for the patient or not important of the patient. So I realize when I see these type of students, so I think that they should is the autonomy of the patient, and is the what we can do for the benefit of the patient, cannot do which harm the patient, and how can the justice for the patient. So all these very important things, they should come in the mind of these students. The new, they are coming up, and some sort of things we can give to these students. And about the palliative sedation, this is another important symptoms. Why palliative sedation is in patients? Why these need that patient's death should be any intractable symptoms which is very terrible to the patient, this should be removed at the time of death. Why it is important? Why? Because everybody has wants good death, as जैसे कि हम लाइफ एक्सपेक्ट करते हैं, वैसे ही हम जब देखते हैं तो स्टूडेंट्स नॉट टॉकिंग अबाउट द डेथ. जैसे हम कभी क्लास लेते हैं, कभी पढ़ाते हैं को या स्टूडेंट्स को, तो डेथ के बारे में ज्यादा बात आना ही पड़ता है, बहुत ज्यादा वो इंटरेस्ट, एक फियर है, वो नहीं बात करते बहुत ज्यादा। हमें इन बच्चों के बेसिक नॉलेज में ये चीज हमें जरूर डालना चाहिए कि डेथ भी उतनी ही इम्पोर्टेंट है जैसे कि शुड। सो पैलेटिव सेडेशन की इम्पोर्टेंस क्या है, क्यों हमें चाहिए, और क्या क्या इसके साइड इफेक्ट्स हैं, जैसे डबल डॉक्टर बताना चाहिए। ये सब चीजें are the things which should MBBS fourth year or final year student in my view.
Thank you for sharing your experience in teaching, Dr. Sarita. Yeah, as I said, they'll be learning the ethics in the 8Com part little early. Maybe they'll be seeing that when they come to this. I mean, they'll be seeing that all through their clinical posting, but maybe we can emphasize or start from the ethics that they have learned in the early learning period, and
Yes.
actually implementing and practicing or seeing that in practice where they can get confused with all these dilemmas probably. So this will be a hands-on training for what they have seen in the initial part of 8Com. Thank you so much, both of you, for sharing the group work. Dr. Rajagopal?
Thank you, everybody. Priyanka, not a disagreement with anything that you mentioned, but just one clarification.
Yes.
When we say no need for treatment, it can be misleading and can be very painful for the person or the family. Nothing to be done. It's almost like saying there's nothing more to be done. We keep saying, we keep professing that there is no situation where nothing can be done. There is always something to be done. So we'll be specific a little more and say there is no more any need for aggressive disease-specific treatment. And instead, we'll continue to look after him with a view to comfort, make him or her as comfortable as possible. So, I mean, sorry, maybe that's the way you meant it. Just wanted to specify that. Secondly, what's our objective of this training? Okay, it would be nice if people who are dying after a prolonged illness were in a palliative care center or hospice, but that cannot happen to even 0.1% of the dying people in our country. Our main objective, let us be clear, is to empower these students to at least handle the basics, to help them to accept mortality themselves, and to help them as much as they can as young doctors to support patients and families. So the shifting to a palliative care center, referral to a palliative care center will only be for the tiny minority. And finally, Sarita, I totally agree with what you're saying. If when my time comes, I do hope Sreedevi and colleagues will not hesitate to give me palliative sedation if I need it. Having said that, generally in any group, doctors and nurses find it very difficult to talk about it till they are familiar with palliative care. Because the fine line between palliative sedation and euthanasia is not easy for them to see. Because palliative sedation, in the vast majority of patients, within hours or a few days, ends in death. And they are saying this is practically euthanasia. You are sedating them so that they will die. It's very difficult for them to understand. So maybe I personally, that's not a medical opinion or an academic opinion. My personal opinion is the concept of palliative sedation may be a little too early for early undergraduate students. Instead, it may be safer to say that if it is so warranted for symptom control, for control of delirium or other symptoms, we should not hesitate in giving adequate sedation to minimize the symptoms. So thank you.
Thank you, sir. I think that was exactly the question I was about to ask. Like, it's a very delicate topic. So, how to deal with that topic when you talk to students, how to start and how to get the right point to be conveyed. Thank you so much. Any questions before the last group? If not, we can go to the last group probably.
Sri, on the chat box,
Sir.
I have shared the
Yes,
link
sir.
to the ICMR document
Yes.
with a specific reason. Several terms came up here. Like Mrinal mentioned, futile treatment, futility of treatment. We were talking about palliative sedation and euthanasia, active euthanasia, passive euthanasia, etc. Because any discussion on palliative care, on end-of-life care, to a non-palliative care group, almost invariably brings up the question of euthanasia. I think we need clarity on that. If you look up just the executive summary, we can see the definitions, and it would be good to have it ready with us so that we are able to deal with those questions.
Thank you, sir. And we have shared that link in the WhatsApp group. And I understand that we have shared the same during our end of life care session. If not, we have just put it in the WhatsApp group. So it's handy. You can just click on the link and read. So group 5. Dr. Umesh, Dr. Shah, Dr. Suranjan, Dr. Sunita. Yes, yes, ma'am, please.
So here we are taking 2 hours for the session, 1 hour for the goal of care discussion and the other one for prognostication. So first one, the objective is to discuss situation where goals of care discussion are relevant, taking different case-based scenarios and discuss the framework for goals of care discussion and comprehensive care planning. Like doing a family meeting. So taking the physicians, ICU physicians, palliative care physicians, and the family members. So deciding the care plans and explaining them to all the treatment modalities, all the treatment options, and the treatment which we are going to give, means the role of inappropriate treatment. I think which is usually the typical healthcare scenario. In the last end of life, we used to take our patients to ICU and just at any cost, we are requesting the doctor to just get him cured. So in that case, you should always explain the disadvantage of that futile care and tell the way how you can make the patient comfortable. So like at home, how they can take care of the patient, and that is means at this point of time comfort care is really required rather than the ventilator and other inappropriate treatments. And some kind of continuity of care should be there, like you can suggest some palliative care unit nearby with a home care team. Those they can also help them. And the other part is about the performance scale. They should know, this is very important to know the different prognostication tools actually to identify patients at risk of imminent death. So those are what are the points you should tell them, the students, how to identify the patient is going to die, imminent death. What are the signs and symptoms? And of course, this about that management of distressing symptoms, like and different type of tools like scales, like palliative performance scale and clinical frailty scale, Karnofsky scale. So all those things they also need to know to prognosticate the patient and the disease also. So, and all these things, for this you can take a didactic lecture with PowerPoint presentations and few case-based scenarios, and then you can divide them into different groups and giving them different case scenarios, and after that ask them to present individually, and I can evaluate them through some MCQs or short question answers, and a video on end of life care and the role of palliative care at end of life. So that also can be shown to them. Video.
Thank you, Dr. Sumita, for summarizing what your group have been discussing. I would like to ask in general to all others. So we have heard about interactive lectures and group discussions. Any other teaching techniques that you can think of? I'm just asking, is there anything else that we can? Videos, yes. Is there anything else that you usually use in your practice already, which you can share with others? It will be helpful for everyone. Sir, while they think just thinking, is there any other way that we can take these topics?
No, Sreedevi, you have been working on all those NHSRC things and so many things. So I think you would know enough, and I am sure there are many experienced teachers here. One of the challenges will be in getting enough time. The only problem with group work is that it takes time. Even if you are very strict with the time of, okay, 7 minutes, something like that, discussion may not be useful. And then when they come back, there is no time for sharing. So they do the group work, but there is no time for feedback and learning. So it may get wasted unless we plan it meticulously. The subject for group work should be very small. One question, a vital question, not just any question, one vital question alone to be answered, not a broad subject. But many of you are quite aware of all that anyway. No, Sreedevi, I am happy.
Thank you, sir. There is a chat telling that maybe we can use self-directed learning, which can be combined with these lectures so that there is kind of reinforcement. But maybe in the beginning, if you think about self-directed learning, maybe they get confused because of the ambiguity in the topic itself. So I think after the lectures and the discussions, maybe for reinforcing what they have learned, a little bit of reading material. I just think someone was mentioning about asking for personal experience. Probably they can write it down if someone wants to share. So that may not take much time. But then we can create a scenario from that and start discussing that. So there won't be loss of time in the classroom as such. Or if they are exposed to end-of-life care patients or in ICU when they are in their other postings, maybe we can ask them to come back and write a very small reflective writing. That's one way of just engaging them in all these conversations. And role modeling is very important, as I mentioned in the beginning. You teach something and then they see something else when you are with patients. That may be something which we may not want to happen. So when we teach all these communication skills, we have to role model for them. They'll be really looking forward to seeing this when we practice. So that's and that's an excellent way of teaching also. And they see you doing all this, that they remember for a long time. Thank you so much, all the group members, for the wonderful discussion. Today is the last day of our program. We will be sharing a feedback link soon. But if we have 5 more minutes, so if there is any critical feedback on the whole structure of the program or whether it was useful or not, so I'm happy to take a few because we have 5 more minutes to close the session. Or you can write to us if you don't want to criticize in front of everyone else.
Okay, okay. So, Sreedevi, especially for
Sir,
criticism,
something
will
for
it
the
be?
next 5 minutes. I would request sir to speak something for next 5 minutes.
I
And I
was.
think Dr. Rupam was about to tell something. Yes, please.
And
So-
was that actually we have our traveling time from 3:15 to 3:45. So active participation was, in the form that we could contribute to the presenter, but we were not very comfortable in presenting in that time. Earlier in our feedback also, we suggested that if the time span would be somewhere in the evening, then it would have been more comfortable for us to interact and, participate in a more wholehearted fashion. Because we are, literally worried to mark our biometric around 3:10, and then there's a long queue. You can well understand it can't, I mean, knowingly or unknowingly, it was not possible for us to interact in a very, enthusiastic way. We did want to, but this part is just a suggestion. The time constraint, I mean, the time span was not very comfortable for us. Otherwise, it was very enriching and a very nice and different experience for us. And I thank Team Palium for everything. But just the time span was not very comfortable. This is just I wanted to add. Thank you very much.
Thank you, Dr. Rupam, for pointing it out. So even for the foundation course, we are running two courses. One is 3 to 4:30 and other is 5 to 6:30. Because as you said, different institutions have different time. Some
Yes.
people would prefer to finish it during their duty time. They don't want to go home and
Definitely.
attend the session.
Definitely, definitely. Ma'am.
So some
Yes,
people
ma'am,
don't
there
want
are-
to do it from home. That's
there
our time. So let's finish it off by 3. So yeah, based on that, we run 2 timings. So maybe we'll give that again. There is another
Right.
course happening at 5 to 6:30. Probably we'll give it an option that either 3 to 4:30 or 5 to 6:30. That we'll look into it.
Yeah.
Anytime
Yes,
we
ma'am,
implement, there'll
absolutely.
be some people might find it inconvenient.
Definitely.
So we go for the
Definitely, Dr. Sreedevi. Yes, it was just my opinion. I just wanted
Yes,
to
thank you so
share
much. Thank you
just
so much.
type of feedback. Thank you,
Thank you
ma'am.
so
Thank
much.
you.
No problem. We are happy to take feedbacks. Thank you so much for sharing that. So I think so the whatever materials we have shared, please feel free to use them. And as I said, there are areas where we can get involved in teaching, starting from the foundation course, along with the preclinical department, till the electives block 1 and block 2. There are certain institutions who do block 1 in a hospice and block 2 in the palliative care department. And I am sure that you all know that you can always send students outside your institution. You can send it to a hospice, you can send them to an NGO, you can send them to any community-based organization. So it's the institution may not come up with all these plans. We expect you all to approach in these areas. These are the areas we can actually take leverage and tell them that these are the electives. As Dr. Jayaprakash was mentioning, they do hospice care in block 1 and palliative care in block 2. So you can always send them outside. You can have collaboration with other organizations. That is quite clearly mentioned in the NMC guidelines. And there are templates into which we just have to write the learning objective. We are sending them, just write specific learning objective, like what do you want them to learn. So if you need any help in creating all those, please approach us. And if you're planning to take some session and you think that you need some videos or you just want to ask some resource materials, please write to us. We are happy to do that. So all the materials, as Dr. Umesh said, it's like ready-made. You just have to go through it once. It is ready to use. The notes are there, so you can just put it in the presenter view. So under each slide, we have put notes wherever it is needed with all the activities mentioned. So if you need more, because there are more topics, we are not able to cover the whole topic in the faculty development program. We covered only communication, pain, and end of life care. There are so many more topics which I have shared the list of topics and the year in which you can do that. So in whichever specialty you are, please try to take leverage of this guidelines by the NMC and start implementing. And we'll keep in touch during those periods.
Sri, this is the second or third FDP, I'm sorry.
Second,
I
sir.
forgot.
Second.
So is there a community of participants who have gone through the FDP program? Because I believe jointly these groups to getting together could be a very strong workforce for the future, for as a sort of leaders for the whole country. And then they can possibly share experiences, and especially if there are medical students organizations or formal or informal groups, it would be great to have be connected to them, because they can be such strong allies.
Yes. We are meeting with an informal group of medical students across the country. So they say they have representations in all the medical colleges. It's called Medical Students Association of India. So we were thinking to link you with them. So these are students who are interested to learn palliative care and take it forward. Now we have a list of you who are interested to teach this. So if once we have the meeting and we get the details, we'll probably put this both ends together so that the students will be helpful for you to facilitate this in your own institution. So that will be done in the coming. Thank you, sir. We'll develop a community.
That's also very good news that you have that connection with the group. I hope that in that matter, you work closely with the state facilitation team, because there are so many things to be done through that organization connection with them.
Yes,
Thank
sir.
you.
So most of these faculty members came through the state facilitation team. Yes. Thank you so much, everyone. Please, we'll be sending the evaluation of our own sessions in the coming days. So please feel free to give your valuable and honest feedback so that we can change anything which needs change or improve our own training programs. Thank you so much, everyone, for the interaction. Thank you, Dr. Umesh, for your valuable comment. Thank you so much.
Hello, everybody. I look forward to working with you all of us in Palim India. Thank you very much.
Sure, sir.